Our next speaker is the nurse manager at a 36-bed level 3 NICU, and that is a hospital that is very near to here. It's about an hour away in Sarasota, and one must cross a very scary bridge to get there. If you're not a fan of big bridges and high winds, you want to go the long way to Sarasota. This person is also the manager of maternal neonatal transport. Interestingly enough, one of our other speakers today, Dr. Stephen Powell, is also specialized in neonatal transport. So they are like-minded individuals, and I think they didn't know that before today. This person has been at her hospital for 29 years, and she joined after graduating from the University of Florida, where she expects, I was going to say hopes, but I would say expects to be granted a Master's of Science in Nursing in March. Her hospital is a 3-time Magnet Award winner, which places that hospital in the top 1% of all hospitals in the country. So it is my pleasure to introduce Debbie Harmon.
Wanted to invite anybody that wants to come to Sarasota. It's on the West Coast, about 50 miles away. NICU nurses are very touchy-feely kind of people, so as we go through this process and our journey, if you ever want to come to Sarasota, you're more than welcome. It's going to be 80 degrees there next week, so if you're tired of the snow, please call us, and you're welcome to come anytime. And I just wanted to add, this is really wasn't part of the presentation, but Dr. Wyatt brought up so many good points about culture and about communication. And does anybody in the room know about team steps? Good. Our hospital instituted that a couple years ago, and it's a journey, just like Magnet is a journey. It takes several years for it to become enculturated. But I really would encourage you all to go back, and you can look it up. Just Google team steps. And really what it's about is the basic things that we do most of the time, but it just puts a name to it. So it's about SBAR, right? And we use this in our interdisciplinary rounds. Every morning the nurse presents the case, and we use the situation, background, assessment, and recommendation. And it's also about briefs. So in the morning when the staff first comes in, we all go to the nurse's station, we have a brief. Not only do we learn about the assignments, but we also talk about high-risk cases or potential discharges, potential admissions. And then we have huddles. So if an emergency, which frequently happens in a NICU, comes up in the middle of the shift, you can all get together real quickly and designate people's roles in what's going to happen in the event that's going to occur. But my favorite part about team steps is the debrief, because we've learned so much through debriefs. Debriefs can occur, anybody in the unit can say, I want to debrief. And typically it ends up occurring after a delivery or a situation that didn't necessarily go the way you planned it to go. So everybody's, and you know, we've all had those experiences when we went home after the end of the shift and kind of beat ourselves up about what happened, what could I have done, what did I miss, and so that kind of takes that piece away, and you get in a group of everybody who's involved, from the housekeeper to the physicians to the nurses, and it's not about blame, it's just talking about what happened, what went well, what didn't go well, and then what comes out of it is the recommendations, and to me that's the most important thing, because we've gotten such great recommendations for quality and safety. And just as a quick little example, we actually had our first neonatal death in the unit since moving about a year ago. And what we realized, you know, in our old unit, and you'll see a picture of it, we were right next to labor and delivery. So if they needed us, they'd go over the squawk box, we need you in OR3, and we'd go running over. But now in our new unit, labor and delivery is on the 4th floor, we're on the 5th floor, mother baby's on the 6th floor. So what we realized is we don't necessarily know what's going on in each other's units. So at the time we were having this code in the NICU, they had no idea, and they called a C-section at the same time. It was a non-urgent C-section, but we didn't really have the manpower to do it at that time. So one of the simple solutions that came out of that is, as soon as we have a code or an event in the unit that involves a lot of the staff, we Voalte, or we text or we call labor and delivery right away and say, we're having a code, so any unnecessary deliveries, just hold off right now. So that's just a simple thing you can do, talking about debrief. So I thought that was important to share in a group of people who may be facing the same challenges. So let me go on to. So it's, like I said, Sarasota is located in Florida. We're the second largest hospital as far as beds in the state, and it's been a very, very busy season for us. We were founded in 1925, and we're a public hospital, and we're governed by a 9-member board. We're fully accredited with Joint Commission, and our next survey we're expecting anytime between now and July, so we're preparing for that. And as mentioned, we received our magnet designation in 2014, which is 1 month after we moved into our new unit. So that was very challenging. But you know what? The great thing about it is we had so many staff involved in this process that they could easily speak to it, which feeds right into magnet. So it was a great opportunity for us. So these are some of the objectives today. You know, I wanted to step back again and thank ConnectAll for having me here and also having the opportunity to put these events together. I've met so many people during this last year from all parts of the country that I feel like are friends now that I can go to and ask questions. And yesterday we had a great roundtable event where we sit around and talk about what's going well, what's not going well, and ConnectAll is very active in listening to our concerns and how they can help us fix those problems. So I just want to thank them for giving us that opportunity. So the objectives today is understanding the complexity of alarm management. When I learned yesterday that there were so many NICU people in the room, and I think we're all on that same journey. So many of us are going from open bay wards to private rooms, and you know, we're doing the best we can. We're leading the way, and so there's not necessarily a right answer. And so I think that's part of this is learning from each other. One of the things that I think that are different about our unit and our hospitals compared to maybe some of the other speakers you will hear is that for Middleware, we're the only ones in the hospital that's using it for alarm management at this moment. And I think that's a disadvantage because I see the potential of Middleware, but it's a lot of people just don't understand it. I mean, it took me a long time to really understand that Middleware process and how it can help us. So just the stakeholders, as we talked about before, stakeholders, you know, you have to have buy-in from everybody to make this work, right? And so one of the things we did I asked every staff member in the NICU is we had probably 8 different committees in the planning process. And we were very fortunate. Our administration allowed us to be very active in the design of the unit, in deciding what equipment to use. So we had multiple different committees, and of course one of the committees was a communication committee, and I'll talk more about that. Alarm fatigue, you know, I think we're just at the edge. I look into the future. You know, right now we're just doing alarm management from vital signs, but we have medication pumps, we have feeding pumps that we haven't even touched yet in our hospital as far as how we're going to manage those alarms as well. Tailoring alarm parameters, you'll see that's one of the benefits of ConnectAll. It gives you so much flexibility and variability in the changes that you want to make, and understanding and reviewing the data. So this was our old unit. It's 20 beds, but in this particular room, you can hold 13 beds, 13 beds and 7 beds in another open bay area. To me, this was so much more overstimulating than the unit we're in now. You can see it's bed, bed, bed. There's monitors over each bed as well, and the nurse had to sit between each of those beds and document. And the phone's ringing, and you had oscillators and vents, but that's what we were used to. You know, NICU nurses are always NICU nurses. They don't leave, right? They stay, and this was very comforting in many ways, because as my friend Dana would say over there, we didn't need alarm management. I could say, hey, Dana, go check that baby that's alarming, and that's how we lived. It was very secure and safe. So how do you take a person and turn them into technology, you know, in a new environment that is so very different? So we started the process several years before moving, like I said, and we had the diagram of the new unit out so everybody could look at it and kind of start to get a feel of it. Interestingly, you see, like I said, many NICU people here. Do you cover your giraffes like that for those NICU people that are here? You cover them. So it was interesting because one of the comments one of the nurses said is, when we move into this new private room, I'm not going to be able to see my baby, right? Well, I said, you don't see your baby now, right? Because it's covered. So when I said that, it was like a, oh, an aha kind of moment. So this is our new unit. This is one side. We have two sides like this. It's when we talk about a football field, it's a long unit. We have 4 different pods. This is typically what my office is actually right in the beginning of this picture. So some days I walk in and I look and I don't see anybody and I don't hear anything. I'm like, is anybody here? Are they still alive? What's going on? But this was in the beginning of the shift, so I'm sure they were all in their rooms assessing their babies and getting ready for report. But one of the things we mentioned Prescaney earlier, and we are on Prescaney as well, and so we've shown through Prescaney that we've dramatically increased the perception of the environment. So, for example, one of the questions for Prescaney is specific restfulness of the NICU, which in December we scored the 99th percentile, which we were very proud of, as well as privacy at the baby's bedside, which we're in the 99th percentile as well. And parents love the privacy. We have curtains on each door. They close the curtains, they close the blinds, they close the doors. They love, love, love their privacy. And it has been very beneficial. We were talking a little about this yesterday. About a quarter of our population is neonatal abstinence syndrome for babies. I'm sure we have that in all our units, substance-exposed newborns. And in our old unit, there was HIPAA didn't exist. I mean, everybody knew what was going on with everybody else's baby. And those moms were, I think, embarrassed or afraid to come in because that baby would always be crying and all the other moms would look at that and think, what's wrong with your baby? Well, now those moms spend so much time in the NICU, and they develop that bonding. And I really think more of them are going home with the families because of that reason. They feel a little more secure in the environment that they're in. So one of the questions several questions we had to look at as we were preparing this is, how do the parents perceive this environment? Do they feel safe as well as do the nurses feel safe? So it's interesting because it's not the alarms from the monitor. I've never had a parent complain that nobody's responding to a Brady or an apnea or a low pulse ox. What they complain about is the med fusion pumps or the feeding pumps going off because those don't come to our Voalte, and so there's not an escalation plan for that. So I think that's one of the things we'll have to work on in the future is how we're going to solve that issue. The other thing you have to do if you're moving into a unit like this is go through the scripting piece with the nursing staff, is how parents want to know that their baby's safe even when they're not there. And if the nurse isn't there, who's watching my baby? So you have to have that scripting of, even though I'm not in the room, I know exactly what's going on with your baby because all the vital signs come to my phone. I have a buddy who's my partner for the day. So if I can't get to your baby as soon as possible, I know my buddy's going to be there. And talking about that culture, that buddy system, you have to have a really good buddy system. And we've talked a lot about this in our unit. I'm not asking that person to be your best friend, but it has to be your partner for the day. You have to have each other's backs and know you're going to cover each other, and that's part of the safety feature. The other thing I've learned is it's not just like technology and the alarm management, but you have to have other ways of communicating. So we have visual cues as well as other auditory cues. So you can't really see it here, but outside of every door there's 3 different lights. One's orange, one's green, and one's purple. And as we planned this, we thought the orange would be for the nurse, and the green would be for RT, and the purple would be for the parent. So as I was going to the room as a nurse, I would push the button. So if my buddy needed to know where I was, they could quickly look out and see the orange button. Didn't go well. The nurses don't do it. The respiratory therapists don't do it. But the parents are phenomenal. We teach them, when you go in the room, push the purple button. So if I'm as a nurse in another room and I can see, the purple lights on my family's come, because I might not know they've arrived. So that's been very helpful as a visual cue. The other alarms we get, we attend many, many deliveries in labor and delivery, so we also have a delivery team. And so in the morning, you might be assigned to be on that delivery team. So there's, in the ceiling, there's an auditory alarm that goes off. So in labor and delivery, there's a now and a stop button. So this was one of my biggest fears is, are we going to get to the delivery on time? Because we're down a whole nother floor, and we have a specific elevator that takes us right there. But I was just really nervous we weren't going to get there on time. So we installed these now and stop buttons. The now, and it doesn't have anything to do with how quickly you'll get there. It's just an awareness of you need to come. So now would be, we need you in the OR now. So it would come across on my Voalte OR3 now. But the stat, if they should push the stat button, it means I need the NEO, I need the crash cart, I need everything. So one of the changes we made along the way, and it's always a learning process. I mean, you never get to the point where, oh, we're perfectly safe, everything's perfect. You're continuously looking for ways to improve. So the stat we decided to assign to everybody in the unit, every staff, so they know that something's going on. We'll have a quick huddle before they go down to labor to say, okay, we know this is a 26-weeker. You can go get the bed ready, get the room ready. So that's been a big help for us as well. So this is another picture. So this is a private room here. You can see there's a GE monitor on the inside there. And one of, I think, the great thing, and it's so important to have a good concept of what kind of design you want to have for your NICU. We were very fortunate in our planning stages that several of the hospitals in the Tampa Bay area had just completed a renovation or built a brand new NICU. So we went to 3 hospitals, and we feel like we took the best of all of them and put them into our unit. So not only do you have the monitors on the inside, but you have monitors on the outside, and the nurse actually documents at this little station too. So, and again, it's hard to see, but if I'm standing, you have your respiratory side, which is the right side, and the nursing side, which is the left side. So I have clear visual view of 4 patient monitors at any given time. So I have my patient. There's a window that separates the 2 rooms that I can look through, so I can turn the monitor so I can see that baby's vital signs as well. Or I can look across the hall, so if I have patients on the other side, I can see the monitors on the outside as well. And so that's where most of our alarms are acknowledged. They don't even necessarily escalate to our phone because we're getting to them right here, which is a really key. And that, I have to give credit to the GE vendor who we worked with. It was his idea to put those monitors outside. I just thought it was kind of overkill, but it wasn't at all. It was a great idea on his part. But you can see the beds are still covered, so you still can't see your baby, right? You still have to go in the room to see your baby. The other things at the bedside there, what we have is staff emergency and a code blue button there, which comes to our phone as well. And we also have a nurse call, so if the family's sitting in the room, we make sure we put the nurse call button by their bedside so they can easily access it.
Can I ask a question?
Absolutely.
Is it alarming in both or just the one?
It does alarm in both. It does alarm in both. And the great thing you can do is, if I have patients down the hall, you can split your screens. The one mistake we did at first is we had this, you could only split your screen either on the inside or the outside. You can't do both. So we split the screen on the inside, but what we realized, if I'm monitoring the kid down the hall who's desatting all the time, it's keeping that family awake. So we just recently moved it to the outside. And please ask questions along the way. You don't have to wait till the end to do that. So stakeholders. So in the beginning, so many people are involved in this process. The nurses, we had mostly our charge nurses were on this committee. And we have our respiratory therapists, our multi-skilled technicians. Some people might call those HUCs or PCTs, but we call them multi-skilled techs. They are so important, as you see, as designating and assigning rooms, so who goes where. And we have actually 4 different systems that the MST has to assign a nurse to. So they have a very important role in this. Information center systems, all vendors coming to the table. I cannot stress that enough. They all have to be willing to play in the sandbox together, and they have to be willing to work collaboratively and not say, you're responsible for this, no, you're responsible for that. You gotta have a good relationship. Quality and risk and physicians as well. Actually, my medical director's here today too, so he was very involved in that process. So the integration of 3 different systems. So we were fortunate, like I said, the staff got to choose. We were very much a Phillips hospital for all my nursing career, but at this planning stage, we had the option of looking at other monitors. So the staff selected the GE monitor. And the hospital had already integrated a communication device, which was Voalte. So we had already been starting that, although we didn't start, I think the NICU was one of the last units to use it because we didn't really have a need to at the time. But we proactively had them start using it probably about 2 years before we moved because, the average age of a nurse was 47, 48. Texting was not that big back to 2011, at least not for me. And I said, okay, you have 2 years to learn how to text, right? At least do that. Learn how to text. And now they're all phenomenal. Even we have cuddlers, volunteers that come in and hold their babies, and their average age is probably 70s something. They actually use the phone, too, to communicate. So the last piece of this puzzle that we had to look at was middleware. And I didn't know what middleware was. I had no idea. So luckily, I had a biomed manager who I have known for years. And I said to him, I knew what the vision was. I knew what we needed, but I didn't know how to get there. And so luckily, he's the one that said, oh, we have to get middleware. I'm like, okay, let's do that. But So for those of you who don't know what middleware, it really took me a while to understand, because you have your GE or whatever monitor device you have. You have that doesn't change. That device is going to alarm just as it always does. The key is deciding which of those alarms and at what increments of time do you want it to come to your phone. So it's really about transfers alarm signals from equipment to cell phone for clinician alerts, allows clinicians to determine which signals are high versus low alerts. And that's the great thing with Connexall. I think that's one of the reasons we selected them. We talked with 3 different vendors, and this was a long process. It probably took us a good 6 to 8 months to select which middleware company we wanted, because the other ones are very ingrained. Everybody probably knows this. ASCOM is with GE, and Emergent is with Philips. So they're very ingrained with each other. And that was the great thing for us, I think, about Connexall, is they didn't have that. They were very independent, and they could work with anybody, and they were very flexible in giving us lots of options. So this is our Voalte communication system. We just recently went to the Motorola MC40, but this is actually a picture of the iPhone-based Voalte that we're using. So this is just kind of what it looks like for us. If my patient's going off, it'll tell me the room number, and it'll just tell me low sat. And I can either accept it or I can escalate it. If I'm busy, if I know I'm starting an IV or if I'm not going to be available, I can preset it to busy, so it all automatically escalate to my buddy. So with your Voaltes, you're able to receive texts, phone calls, both incoming and outgoing. Your alarm management, we receive our code alerts over this staff emergency, and our delivery team comes over Voaltes as well. Yeah.
So it doesn't say like SPO2 what
No, but I want to do that. I learned about that yesterday. Yeah, what she's saying is now I guess there's systems that you can actually see the waveforms.
or even the values, just the values.
Right.
Yours doesn't give the values.
It doesn't, not. It doesn't right now. I'm sorry. Yes. Yeah. Yeah, so I would almost rather see the waveform because the desaturations are the ones that are the most hard to manage. So if I can see the waveform and see, okay, my baby's coming up, I don't have to, or the baby's going down, my reaction time is going to be very different. So for me personally, I don't know what other people, but I would rather see that waveform so I know which direction my baby's going. So these are some of the questions we had to work on as we were planning this. Identify failures and determine causes, and how did Connexall help us with these issues? So when you're planning this, you're thinking, okay, how is the backup going to work? What is an escalation plan? What does that look like? It was kind of, for me and the team that we worked with, we didn't really know what we were doing. It was all kind of a guesswork based on our best intuition, really. So you set up which alarms, and nurses, especially NICU nurses, we're very anal people. I know, we're very passionate at what we do, but we have such a low tolerance for any kind of mistake. So what is the escalation plan, and are the staff going to buy into that? And again, going back to your buddy system, I really need to count on my buddy to be my right-hand man. What will the family think? I kind of touched on that a little bit. are the right nurses receiving the right patient alarms? So we'll go through that in a little bit. And actually what we did is I've asked the staff, I'm not going to say they do this all the time, but I asked that when they first go do their assessment, they disconnect the leads. Because you still have your pulse ox, so you know what's going on. But if you disconnect your leads, and if you wait a minute, you have to see if you're going to receive the alarms. That's just a double check of making sure I'm assigned to the right patient. There's probably other ways to do it, but that's how we've decided to do it. And alarm fatigue, I think that's just an ongoing process. I certainly don't have the answer to that, but we had to put it up there. And competing priorities, everybody, nursing, you have more patients, less staff. How do you, and I think that's probably the biggest frustration in nursing is I'll hear nurses say, you keep giving us more and more, and what are you taking away? So that's a hard one. But I say we have taken some things away. Yes?
Go back to your initial test at the shift. How many times have you found that to be a problem? Where it was going to the wrong phone, or it wasn't?
How many times? Once in a while. Really not. My concern is if you're having a really busy day and you get a lot of admissions or discharges, or if you have to change a nurse's assignment. We haven't monitored that, and I know that's something I need to do. That's the piece I worry about, because then the MST becomes very busy. She's admitting patients. There's a lot going on. Where on her priority list does that fall? So that's something we need to pay attention to. But you know what? As I think about it, nurses start to realize, because you can see it on the monitor. And so if you can see it on the monitor and it's not coming to my Voalte, it's a good time to check, oh, am I connected to the right patient here? So this is what the board looks like that the MSTs work. It's very simple. It's just a drag and drop. So you have the room number, and the first box here is your primary nurse. And then the second, and there's multiple ways to do it. This is just how we decided to do it. In the second tier, you have your buddy and the respiratory therapist. But the respiratory therapists are only assigned to those rooms for a baby who's on any type of respiratory support. If it's just a grower feeder, they're not assigned. The third tier, originally when we did this, went to the charge nurse. But what we realized somewhere in a few months after we initiated this is like the primary nurse was dropped from the system. She never knew if it was actually resolved or not. So we added her back to the third tier. So now the third tier is the primary nurse and the charge nurse. But it's a very easy system to use. So this is what we started with back in September. Well, we were fortunate, and I would recommend this to anybody if you have the option to do this. We were able to get 10 new GE monitors into our existing old unit. Like I say, staff first had to learn how to use those monitors. That went great. That was not an issue. And again, nurses think they want everything. I mean, they thought they wanted every alarm because they want to feel safe. They want to know what's going on with their baby. But in our communications group, we tried to be so cognizant of the alarm fatigue and alarm management, really choosing the right alarms that are actionable. Well, we were way off. I'll just tell you that we were way off. So this is how we did our escalation system in the beginning. This has changed multiple times since then, but we had Brady, high heart rate, low heart rate, high pulse ox, low pulse ox. You can see what was there, and everything was in 15-second increments of escalation time. We started the alarm piece in October. We were moving in November. I wish we had had more time, so we were talking to somebody. If you have more time, initiate it as soon as you can, because it is a big learning curve. So we started this in October. Luckily, I had a Voalte person there, and we had Connexall on the phone, I think, the whole morning. When we first did it, this is what I felt like. That morning it went, I'm like, oh my God, what have we done? This one nurse, our token male nurse that we have, he still comes to me. I went to him actually as I was preparing for this presentation. I said, how many alarms was it you got that first day? He got over 700 alarms that first shift. I thought, oh my gosh. But Voalte quickly had other hospitals that they got on the line and helped us problem solve. And then we were able to get right on the phone with Connexall so we could make immediate changes.
Can you go back one slide?
Yeah.
So I have a question for you.
Yes.
I understand your escalation. What I want to find out specifically is your delay that you put on your pulse ox before an
So if I
GE
understand,
monitor automatically has a 5-second.
Correct.
Automatically. Did you add anything to that? Or
so
did
it's
you just
15
accept it?
second, no, there is a 15-second,
You've added a 15-second delay to the pulse ox on the GE monitor before you go.
not on the GE monitor.
No, that's what I'm asking.
Yes, no, the GE monitor
You
is,
accept the default of 5 seconds.
so if I'm at the bedside and I see it, I can hit my GE monitor, I go to the bedside and hit my monitor before it even escalates to my phone. If I'm down the hall, it's not going to come to me until 15 seconds after that.
I'm not asking that question.
Okay.
My question is the monitor.
Right,
Don't even think about connecting.
Okay.
The monitor itself
yes,
has a default.
yes,
I don't know if you're using Massimo
Yes.
or if you're using Covidian. I don't
Massimo,
know which one.
Massimo,
Massimo has an automatic default of 5 seconds.
yes.
That's their default. What I was asking is, did you all put it up to 15 or 10 seconds?
No.
Beyond that? That's what I was asking.
No.
And so, okay, thank you.
Ours is 8 seconds?
So you have is that your signal averaging or your?
Yes, signal averaging.
Okay, they're two. So that's the stuff, I'll be talking about that, but I was just curious. So you have a signal averaging of 8 seconds.
Yes.
Which is the default. And then you have a 5 seconds delay, which is
Yes.
the default.
Right. Okay, so then we made some changes in January after being in our new unit. And it was fascinating. We did so many simulations. You know, we tried the equipment in our new unit as much as we could. Any new equipment we had, we tried. We did simulations. We did education. We thought we were really prepared. And it's when you move in, it's kind of like that Maslow's hierarchy of needs. All the nurse could focus on was the baby and where her supplies were. It was like nothing else was there, you know. And it lasted that way. I remember in January waking up one day feeling like this big weight had been lifted off of me because I could tell they actually had come down from the ceiling, and they were able to take it all in and not just the most important thing, which was the baby. So what we did here, excuse me, our high heart rate had been escalating at 15 seconds, and our high heart rate at this time was 200. So we changed that from 15 to 30 seconds. Because, you know, babies cry if you're doing a procedure. It's not uncommon for to have a heart rate of 200. So those were a couple of the main changes we did then. And so this is the first report we did. This is very interesting. So this is looking at the number of alarms per day per nurse that they're receiving in the unit. So if you look back at the blue, the first bar, that was back in September. So remember, we were only monitoring 10 patients at that time. And only half of those was the primary nurse responding to. A third of them were escalating all the way to the charge nurse. So there was a big learning curve in how this process actually works. But we've improved we've gotten much better about this since that time. So here in September, we made a couple of other changes. And here is I wanted to put this up there so you can see over time what we've done. So parameters, low heart rate is less than 80. We changed that just recently because we've been talking about our apnea and bradycardia and how we're going to manage those. So we're now calling it clinically significant events. So we wanted the low heart rate to match the number of seconds that it would escalate to our volt. So we went from 15 seconds to 10 seconds because 10 seconds is what we're considering a Brady. High heart rate, we just got approval to change that to 210. So we're in the process of updating that. And we changed that from 30 seconds to 60 seconds. Again, because really looking at those actionable alarms, what do you want to respond to? What's the most important? So we changed that to 60 seconds. The low pulse ox, we talked a lot about this yesterday. That is the most challenging thing to monitor. Because, you know, you have these 24, 25-weekers, they're constantly desatting up and down, up and down. So I don't think anybody really has an answer to that yet, but that's our biggest challenge. And then the high pulse ox, which for us is greater than 94, we changed that from 30 to 60 seconds. This is constantly fluctuating. And leads off, we went from 30 to 60 seconds as well.
Nancy, have you thought about using in the GE monitor different profiles for gestation age?
We do that. We do that.
So for that baby who's under a certain gestation
Yep.
age, you pick like a lower pulse ox?
Yeah, so we have less than 30, we have 3 we choose, less than 34 weeks, greater than 34 weeks. Then we created one for babies at, what did we call that, Danger? What? No, well, we have PPHN, but for babies who are dying,
Yes,
we had a nice name for it, and I can't remember what we called it, comfort, or comfort, something like that, so. But yes, that's something we can certainly go back and look at as what other, maybe we need to make one for even the smaller, the younger gestational ages as well. And I'll be interested to hear what other NICUs have done as well. So this is our latest data. This goes from September of 2014 to December of 2014. And, you know, our acuity of patients was much higher during this time. So that's why you see an increase. So, for instance, on the red bar where you see 80.46, that's, as for me as a nurse on for 12 hours, I received 80 alarms in that 12-hour period. That means 6.6 alarms per hour. I don't know if that's good or bad. It's what? That's a lot. So that's something we still need to look at. But how much of those are incidental, or just pulse ox, or what else can we look at to minimize those? A lot of it, though, I have to say, is because nurses are at the bedside, but they're not silencing it. So that's a culture change. That's an education piece we have to work on. But now you can see the primary is acknowledging pretty much all of the alarms, okay? Either with her phone by accepting the alarm or doing it at the bedside. And very minimally do they escalate to the secondary and backup. So I think that's a credit to our workflow and the input of all our staff. So I know other people will delve into much greater data than I have, but this is something that we wanted to focus on and make sure that the staff understand the process. So what went well? I think collaborating with other healthcare organizations, either through ConnectAll or using your other vendors with Voalte and GE, and being able to contact those other institutions that are probably ahead of the game than we were and give us some great feedback. Simulations, the more you can do. Working collaboratively with whoever you choose, whatever monitor, whatever phone communication system you use, whatever middleware you use. We do monthly phone call meetings with ConnectAll, which has been very, very helpful. I have pulled IT into it because, as I said, we're the only area in the hospital that uses ConnectAll, and I don't think they really understand it. So I've been trying to pull them into these conversations as well too, and it's been great. There's a couple of issues that we're working on. One in particular, down at the bottom you see, do we need central monitoring? So this came up just recently. Out of the blue, our CIO said, you need to have central monitoring. I'm like, why? This is a person who hasn't walked through our unit. He doesn't understand our workflow process. Why do you feel like we need this? But the good thing that came out of it is I went to the charge nurses in particular. I said, okay, this is what's been thrown out of on the table. Do you feel safe in how we're doing this now? And they all said yes. They feel safe. And I think that's the biggest takeaway for me, is after all the challenges and everything we went through, feeling safe as a nurse is one of the highest priority, right? So the monthly phone calls are great, collecting staff feedback, and constant reevaluation of the process. And what I really need to get better at is digging more into that data and seeing what alarms are going off the most. I really think it's going to be the saturation piece. And I talked again yesterday, well, is it unit specific, hospital specific? Well, what if somebody down the road is doing it very differently than I am? If something bad happens, am I going to be compared to that other hospital? I don't know. I think these are areas we haven't really delved into yet. So we all know the 2016 requirements for Joint Commission: establish policies and procedures to manage alarms, addressing appropriate settings for alarm signals, and details of when alarm parameters can be changed with follow-up monitoring and organizational education. So this is going to be our next journey. We don't really have any policies and procedures. We have it all up here, but it's not written on paper, so we need to start working on that. And how we're going to do that And I think we're fortunate enough to be involved with several listservs to help us, why we recreate the wheel if somebody's done a great job. We're fortunate being a magnet hospital. We are on a magnet listserv as well, so we can access them. And Connexall's ability to connect us with other hospitals via actual conferences where we can see each other, or contacts, or by phone, however we can, whatever works. And working collaboratively with all vendors and stakeholders is huge, huge. And I think I probably spoke way too fast. I don't know what time is it. So any more questions for me?
So you were in your old ICU. Did you have central monitoring there?
No.
So you were just bedside.
Yes. But you didn't need it. We were all in one big room, so you could see all the monitors. You didn't
Where
need
were
it.
you able to take a look at any kind of alarm data?
I'm sorry.
Doing it at the bedside is kind of hard. Well, I have a central station. Could you go back and look anything retrospective?
Well, that was actually something you can go back in the monitor and look. You can scroll back.
But it's kind of hard to do in that open environment.
Yeah.
To actually do it at the monitor. I see you go on and have your secondary monitor outside the room.
Right.
Your CareScape, correct?
Yes.
And that's better than having no central station. So you're actually seeing it.
Well, so here's my thought about central monitoring. So you have somebody sitting somewhere in the unit staring at it. Well, what if my Voalte's down? I mean, I know we feel very comfortable if alarm's going off that somebody's going to respond. We saw it with the data that primary nurse is able to respond to that quickly. But say my Voalte is down or something's down that I already know alarm's going off. But what is that person going to do? She's going to Voalte me to tell me my alarm's going off? That just adds more alarms to me. I don't really see the usefulness. Now, again, I've never worked with central monitoring, so maybe I'm missing something.
But in you went from one big unit to
right.
We're going to a 35,000 square foot unit now.
Yeah.
Closed doors.
Right.
Now all of a sudden, like you have a whole different culture in terms
right.
of how to manage that work.
Yeah.
They did have central stations in there, but they weren't using them.
Right.
Now they go to this big place where we got everybody to closed rooms.
Mm-hmm.
I can see why you went to your decentralized monitoring outside each room. But without that, what else would you have? You'd have to have central stations someplace.
The central stations are very, very helpful if you have arrhythmias. So I can tell you at other sites where they have arrhythmias, going to your central station is a lot faster to pull it up.
Right.
And actually, you can do almost a retrospective halter.
Right.
So that's what's really fascinating. And we can get cardiologists in to do a retrospective halter looking at what the events look like. So there's pros and cons on that, but you need to know your institution. Instead of you saying you need to know what the pros are. There's trade-offs.
I think the layout, and again, I don't know what your layout's huge. We have a backup plan. If something's down, we can do the dual screens. We can see it. We can hear the alarms. We can see the waveforms if we need to. If we need to cohort some patients, sometimes you might only have a pod that has 1 or 2 nurses in it. So if you know you're going to have a downtime, if you need to cohort some patients to give you more resources, you can do that. But I don't see the need. And again, maybe it's because I've never used a central monitoring system before, but yes.
Well, you could have a central station though that's not manned. So that's what I'm trying to understand.
Yeah.
So you don't have a central location where you can see all the beds.
No. And in our hospital, as far as I'm aware, any central monitoring station is supposed to have somebody there looking at it. Now, whether that actually happens, I've heard not, but that's the policy of our hospital.
And it's hospital driven. So there are other hospitals that do exactly what you say. They have the central monitoring bank, but no one is monitoring. It's not manned.
And we have central monitors, and they're not manned. The central monitor is just a way for you to be able to see and pull information, but the information is going to a device. So I guess I didn't understand that you have bedsides but don't have it going to a central spot in the units.
Right.
Yeah.
If I can go back to that picture. Go back to
Right, yeah, that one, yeah.
So there's 8 rooms in each pod. You probably have 2 or 3 nurses in each pod. And so again, the way it's designed, the majority of them are visible. I'm not concerned that somebody's going to miss an alarm because whether people are walking down the hall, I can acknowledge it that way, or it really hasn't been an issue for us.
I understand.
But it all goes to the design, the flow, the culture, your buddy.
But,
Yes.
excuse me, but you have that secondary monitor outside the room. See, unfortunately, we
Yes.
didn't decide to do that, so it's got it inside the room, big, huge unit,
Yeah.
central station, and a Voalte.
Okay,
So I
okay.
can see your advantage of
Yes,
having that in
now I
that
get it.
neighborhood. You can look around without being in a room and see it, which is kind
Right.
of like what a central station does.
I'm going to tell you that was probably the best thing we ever did, was putting those monitors on the, and it wasn't even my idea. Like I said, it was the vendor's idea. It was money for him, but it was a great thing for us, yes.
I just wanted to ask if there have been any issues with silencing the alarms outside of the room and not going to address the patient?
I think it depends what the alarm is, you know, because we're seeing, sometimes that happens during rounds. We'll be sitting there and we'll just, but most of the time it's your DSAT, or it's your leads aren't connected properly. So, no, we've never had, as far as I'm aware, we haven't had an adverse event from somebody not responding to them. Not that you want to wait for that to happen, but, you know, I walk up and down the halls pretty much all day long, and they are very good about responding, or their buddy, or anybody who's walking down the hall.
Okay. Thank you, Debbie.
You're welcome.